Uh, So, good evening to all of you. Greetings from Sexual Medicine Committee Foxy. So, today we are again here with our sixth episode of our unique initiative C2C, that is from confusion to conclusion. So, before we start, we will start our program with the Foxy theme video. Rohit, can you please do the needful?
Dear friends, Foxians, and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari, taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Dira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Dira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
Thank you so much, Rohit. After this powerful message from respected Foxy President Shanta Kumari ma'am, I would like to invite our own chairperson, the person behind this whole program, to tell about what this program is, that C2C. Over to you, Neeraj sir.
Thank you, Apurva. So, good evening and welcome to this C2C series, session 6. So, I welcome our chief guest, Dr. P.K. Shah sir, our guest of honor, Dr. Sunita madam, and Dr. Krishnendu sir, for this wonderful webinar, and our faculty, Dr. K.S.S. Rao, for today's faculty, and our two moderators, very efficient and fluent, Dr. Apurva and Dr. Padmini madam. Why we are doing this series? That is C2C, means confusion to consensus series. Earlier, we did a 6 session of masterclass in sexual medicine, in which we covered male sexual dysfunction, some female sexual dysfunction, as well as history and counseling part. So after finishing our masterclass series, we felt that sometimes we know everything about a particular problem, but when patient come to our OPD, we become confused with so many options available to us. So to clear that confusion, which of management will be better for that patient, we started this C2C series, that is confusion to consensus series. We have already finished 5 sessions, and this is our 6th session of this series. This is a mixed bag case scenario where we will discuss so many different cases related to sexual problem, and which will be put up by our two moderators, and today's faculty will guide us how he will solve these cases, and he will help us to reach the consensus to solve this problem. So once again, welcome to today's program, and I'm sure you will learn so many things from our expert about so many different cases, and you can apply that knowledge in your day-to-day practice in OPD. So welcome once again. Over to you, Apurva.
Thank you so much, sir. And as we know, in our culture, before start any great thing or any auspicious thing, we are always getting the blessings from our seniors. So today we have very special guest and guest of honor for us to bless this occasion, to bless this webinar. I would like to invite our chief guest, that is P.K. Shah sir. Sir doesn't need any introduction. Sir is like guardian for all of us. He himself is like an encyclopedia. Sir is always there for all the blessings. Sir is being the past president Foxy. Sir is being the past president SR, MOG, and whatnot. So he is always there, and always whenever I call him, sir is there. Ha, pur bol. So thank you so much, sir, for all your blessings, for all your support, and over to you, sir, for your kind words.
And
Sir.
sir is always there from beginning to end. He will stay with us in whole program. Listen to all program. That is the fantastic part of
for your kind words, and thank you, Dr. Neeraj Jadhav, for inviting me to be a part of this program. First of all, I feel that out of your 6 programs, I think this is the 3rd time I have joined you as a chief guest, and it is a proud privilege for me to be a part of this program, because sexual medicine is something which is not being talked about so commonly amongst obstetricians and gynecologists. So what you have been doing is something fantastic. Let me tell you honestly, these topics are not read by us. If you ask us, we will not read any of these topics. So when you are live, when the experts talk, I think we listen to you, and we learn a lot from all these webinars. And I wish you all the very best for all your future programs and for all your future activities and endeavors you want to take over. And I wish you all the very best in Foxy. Whatever you want to do, my best wishes are with you, Neeraj. So all the best to you and Apurva, Datta, both of you. Thank you very much for inviting me. I could not join because of some technical problem earlier on. I could not hear the voice. So I have joined luckily at the last moment, and wish you all the very best. Thank you.
Thank you so much, sir. Thank you so much. Next, I would like really, it's give me immense pleasure to introduce our guest of honor for today. First, the Krishnendu Gupta sir. Sir is the pride of not only of East but whole of the India. And I am blessed कि भाई sir आप East से हो. And sir is always there for us, always encourage us. He is always with a smile. है अपूर्व ball की होचे. Sir, thank you so much, sir, for always there, always blessings, always guidance. And as we know, sir, again doesn't need any introduction. Sir is a past vice president, Foxy, at present the deputy secretary general of AOFOG, chairing the reproductive and the sexual committee of AOFOG and whatnot. Thank you so much, sir, for coming there and bless us and for your kind words. Over to you, sir, for your blessings.
Thank you, dear Apurvo. Respected Professor P.K. Shah, my dear friend Sunita, and extremely hardworking chairman of the Sexual Committee of Foxy, Sexual Medicine Committee of Foxy, Neeraj, and of course, ably supported by Apurvo and the entire team. Respects to Dr. T.S.S. Rao here and to Dr. Prasad. Well, I've been associated with this committee for a while now, and while I was the chair of the Sexual and Reproductive Health Committee of AOFOG, I did request Neeraj to, send me some updates as to what he was doing. I thought it was going to be some updates, but I think my hard disk got almost clogged when he sent me an immense amount of data. And I was so proud to present his data to AOFOG, and everybody really appreciated it. C2C always, as far as I was concerned, meant consensus to clarity. But here they are not only going to clarify, but they want to conclude. So it's consensus to conclusion. So which is something amazing. So there's first you clarify it and then you conclude. So I think this is the 6th session, and I'm sure there'll be a few more. And I wish all of you the very, very best, and hearty congratulations to Neeraj, Apurvo, and the entire team, and of course Dr. Padmini. And there's a whole lot of the very, very vibrant committee members whom I see always taking part in these webinars. So it's really a proud privilege for me to be here, and thank you very much for this kind invitation. Over now, of course, to Sunita, and of course back to you, Apurvo. Before that, my request is, as I said, because of the meeting, I'll have to just sign off after a while. Please don't.
Thank you for joining us, sir.
Thank you so much. Thank you so much. Thank you. So again, the next guest of honor for today is again one of my favorite. And ma'am, Lady Chhatrapati Shivaji Na Maja Pranam. I'm trying to speak in few words in Marathi, so I got this. Thank you so much, ma'am, for always being there. Always a very loving senior of ours. Ma'am, as we know, is the past vice president Foxy and the past IAG. And even I know about IAG that yes, he made IAG so vibrant. So thank you so much, ma'am, for taking the academics in that level and to give, endoscopy to even a small cities like us. Thank you so much for always being there, for always your blessings. Over to you, ma'am, for your kind words.
Good evening again. Respected Dr. P.K. Shah, sir. He's a father figure. I know, sir, for last 20 years, and he's just the same. His smile, his way that he will talk, everything, nothing has changed. I have worked with him when he was a Foxy president. I was a committee chairperson. When he was a IAG president, I was also in a IAG actively working as a junior person that time. And Dr. Krishnendu Gupta, you are the most lovable personality of Foxy. Apurva forgot to say you are the past chairperson of ICOG, and the way you have done the work, I can't forget. So this is, and we all are looking forward to the AICOG Kolkata. You all Kolkata guys, you are so strong like a brothers to each other. And I'm sure when there is a unity, when there is no confusion to conclude, then the conference has to become a massive success. Coming to Neeraj, your society, your committee, the Sexual Medicine Committee, frankly speaking, if I would have been a chairperson of this committee, I don't think I would have done such an amazing job. You are doing very amazing job. It's your creative mind and passion for the subject. And that's why the Foxy committee should be taken by the people who have an interest in that particular subject so that they can take that committee to another level and Foxy altogether can be. Now, if Krishnendu has large-heartedly presented your work in AOFOC, that itself shows the Foxy level has gone up. You understand? So this is very good. And everyone, after becoming a committee chairperson, the next step to enter in Foxy is a vice president. And I'm sure, Neeraj, you are looking forward for a vice presidency post. And I'm saying this today, that whoever will be your Foxy president, he will be lucky. You need to have a very vibrant vice presidents to work with. And whichever 6 to 7 committees will come under you, they will be guided very well. So you know what? The right people at right places at right time helps the Foxy to grow beautifully. And I'm watching you, Apurva. You are one of the best committee person. And I definitely feel, I don't know yet, but I feel you have an inclination to take over the chair of Neeraj. And if so, then I wish you all the best. And because, 3 years you have worked with him, you know what is the work going on, and you will continue his good work, and you will put in your additional mind into it, creativity into it, whichever your presidents and vice presidents will guide you more, and you will take that committee. Then coming some third person from somewhere, definitely there need to be a continuation. And Dr. Padmini Prasad, such a senior personality, and you allow everyone to walk, to talk, is absolutely a grateful thing. Dr. Rao, we are looking forward to listen to your wonderful cases. I think confusion to consensus. So today, probably you will make a TOG and we'll come to some consensus with your case discussions. Thank you for involving me. Thank you for having me here. And I'm enjoying equally as you are. Thank you.
Thank you, madam.
Thank you.
So much. Thank you so much, ma'am, for your kind words. Ma'am, over to Padmini, ma'am, to introduce our faculty for today, respected Rao sir, and to start the scientific program. Padmini, ma'am.
Thank you very much, Dr. Apurva. After paying so much of with all stalwarts here, it really gives me a great pleasure to be with you all and to share the knowledge and gain more knowledge. And coming from, as Dr. Krishnendra Gupta rightly put it, confusion to consensus to conclusion. So the conclusion is what we want. So what is the right thing? What is the wrong thing? Because the sexual health and function are important determinants of quality of life. And it is everyone's right to have a healthy sexuality and healthy sexual and reproductive right. And because any disease, any operation, any medication, the psychiatric problems, psychological disturbances, emotions, all these things can play a great role in the sexual the functioning of an individual. So, and Dr. T.S.S. Rao, being a psychiatrist, and he's of national and international repute and lots of knowledge. I can tell walking, talking psychiatrist and encyclopedia of psychiatry, and also the sexual medicine. And he has, I don't know how many, probably he has not kept account of how many conferences he has attended, how many places he has visited. And really, he has got a very great name in Karnataka and a very great psychiatrist. And I can also call him as my guru, because I also have learned so much from him, and through his teachings, and also through the books that he has written. And there's everyone in Karnataka knows, and everyone, whoever is in the psychiatric association, they know very well what he is. And he has got tremendous knowledge. And I'm very sure he is going to give us a lot of clarity to all the problems, the day-to-day stresses, day-to-day problems, any depression, anxiety, psychiatric problems, and various other things. It's a mixed bag that we are going to talk about, and we have quite a few case scenarios, and we are going to put it across to you. I'll just share the screen. Just a minute. So this is an initiative from Sexual Medicine Committee. Foxy, I congratulate Dr. Neeraj Jadhav for bringing in such beautiful webinars and programs to update everyone to improve the knowledge about that, because it is not taught even in medical colleges, the sexual medicine or the sexual health as a subject. And now it is going to give a lot of clarity to all the gynecologists, all the Foxy members. And we have our great people here as Foxy office bearers, our chief guest, our guest of honor, and the moderators. I really thank Dr. Apurva to be a co-moderator. I invite Dr. TSS Rao. Namaste to you all. And these are all our great people who are there with us, and the moderators and the faculty expert of today, Dr. TSS Rao. And going on to the cases, the first case, I would like to put it across to Dr. TSS Rao. Raju always suspects his wife Neetu. He thinks she has extramarital affair. He checks her cell phone, follows her up without her knowledge. When the wife brought him for counseling, looking that something is abnormal with him all the time, suspecting why is he doing that for her, because she was also feeling miserable. And so when she brought him for counseling, when he was alone, he revealed that he has erectile dysfunction. Because of ED and his inability, he thinks the wife has developed extramarital affair. That is his problem. So when such a case is presented, we are at a loss to know whether what Raju is saying correct, or whether the wife, what she is saying is correct, whether she really has extramarital affair, or whether it is just a Raju's suspicion. In such conditions, how we can go about it, Dr. Rao?
Okay. Thank you very, very much. And before I look into this particular case, at the outset, let me just take this opportunity to thank the Foxy for the wonderful opportunity what you have provided, and the confidence what you have kept in me that this whole program can be run in such particular way. At the outset, congratulate Foxy for thinking about confusion to consensus, because in any branch if you take, this confusion is bound to be present, and reaching some particular conclusion some particular way. However, in psychiatry, we are immensely popular as creators of confusion. Not because of anything, but a very simple problem that has been presented. From psychiatrist's perspective, this is just not possible to understand the whole aspect related to who is this Raju, what is actually his problem, and various things like that. But what we will be trying to do today is trying to look into how actually one can reach a particular conclusion, and that way, the type of problem what he may be having, what can be actually dealt in a proper perspective. See, suspecting partner is one of the extremely common problem, and in fact, in any psychiatrist who is a little busy, almost every day, at least there may be one case or two cases. Maybe if we try to look at TV or media's programs and all of that, all these popular medias, they carry invariably a whole lot of programs where he killed somebody and produced different type of problems in the family and all these type of things, because this is extremely common. But as a specialist in this particular field, I won't straight away jump into this conclusion. See, when somebody has suspicions about anybody for that matter, and more particularly, one of the most common type of suspicion people have is actually related to the partner, because in fact, people invest a lot of energy in this particular whole affair. When somebody is presenting with suspicion, there are two ways possible. One is, see, many people carry the idea that women cannot be trusted and one should keep a watch on, and they can ditch me anytime, and a lot of other people are actually preying upon her. These are the ideas which are there, which could be what we basically call as reactive type of disorders. But many of the times, it may be one of the earliest indication of certain major behavioral disorder, what actually the individual will be developing. You all must have heard the term like delusions and all of that. Same. See, one of the things is in case of paranoid schizophrenia, where multiple aspects of our psychological functioning is involved. One important delusion what they may carry is actually the suspicions about the partner. Okay, but there will be a little deterioration in personality, progression of illness in some particular fashion. But unfortunately, what happens, this paranoid schizophrenia, what we call, this is grouped under what we call as good prognosis schizophrenia, wherein you don't expect that amount of deterioration. But the person can actually have a very significant, what we basically call ideas related to what is actually happening. When only one delusion present, say something like suspecting partner. So this grouped under another category of disorder called as persistent delusional disorder. Earlier we used to group under different names actually, but current terminology is actually persistent delusional disorder, wherein there is only one idea. And how actually we differentiate schizophrenia from this particular disorder? Here the individual keeps on expanding this particular idea in many ways. One important point is that initially, whether she is having an affair with somebody like that, say he's checking mobile, then starts checking her clothes. In fact, tells her something and keeps watching her every moment. And he starts blaming others, starts blaming a small neighbor or maybe the relative, starts expanding it to maybe the different people in the locality, maybe the state, maybe the India, maybe the world. This is what we call as systematization. Progressively, they keep on increasing. The third category of disorders is actually what we call as alcoholism. See, whether this particular person drinks, one should almost always, we have to have the information related, mainly because we are all well aware alcoholism is one which can create quite a bit of problems. And there is a syndrome called as conjugal paranoia, or one of the old Shakespearean terminology, what we call as Othello syndrome, wherein, because of course the reason the explanation given is actually he has developed ED, I am not performing. That means she is getting pleasure or something actually from somewhere else. So this is the way actually the whole idea keeps developing. So one has to rule out history of alcoholism and related problems. The fourth one, of course, ED can come to anybody as somebody keeps growing. In fact, I am not sure what is his age, say somewhere around, say 30, 40, 50. As and as somebody keeps growing, some amount of problem is expected in his performance. So that can produce problem. So what I am trying to inform here is actually that chances that this lady will be having an affair and various things like that, even with this very brief thing, the chances are very much less. So the whole idea develops are in fact confines to this particular individual. We have to have a adequate detailed evaluation. Much more information would be available from the partner. In fact, without talking to the partner, if we go by this particular individual, he's developing delusions or certain ideas, he keeps on adding, and he may glorify it, or he may elaborate it in such a way that it may look like as though it is really true. So implausibility, the bizarreness for a very gross disorder like schizophrenia, to very strong definitive idea related to what we call as a persistent delusional disorder, or whether there is any substance related issue. The fourth one, ED itself actually producing difficulty. We need to establish that particular point. How to go about treatment and all? Also, shall I complete it off, or how shall I go about?
What in briefly how what treatment aspect or how you manage such conditions?
Okay.
Now you said that these are all the conditions where delusions can happen.
Hmm.
Because I have seen quite a few the boys or the men coming. I have got ED. I am scared that my wife, you treat me as early as possible. Otherwise, my wife may develop extramarital affair. So this fear is always there, even for a normal person. I come across so many of the men who think that whenever there is ED, they first think that the wife will have an extramarital affair. So
Okay.
that's a basic personality disorder, as you said. They may be having some behavioral problem. So in such condition, whether you just treat ED and watch, or whether you put them on some psychiatric drugs, or how do you manage?
So first, establishing what is the diagnosis is extremely important, mainly because, see, if somebody is having a delusion, either a part of a major psychiatric disorder or any other this thing. Say somebody is having alcohol-related problem. Alcohol dependence syndrome or alcohol-related problem has to be treated first. If somebody has developed this is part of one of the major psychiatric disorder, we must treat that particular major psychiatric disorder. And so establishing diagnosis is extremely important. In psychiatry, see, it is not like gynecological practice in the sense that you examine and there is a lesion sitting there, or if confusion is present, get one scan made and that will clarify what actually it is, or maybe you suspect something biochemical problem, get some laboratory tests done and it will give you. We don't have any such aspects at all. So we have to depend upon what we basically call the partner, the relatives, and whoever it is. Insisting on and getting them is actually extremely important, because whether this is only related to this particular affair and in fact what he's checking phone, it could be far wider and much more way actually it may be affecting. And what we talk about violence, this, that, and all these other related things are also extremely common among them. So if it is schizophrenia, if it is a persistent delusional disorder, we have antipsychotics, sometimes admission and necessary other treatments. If it is a drug-related problem, in fact, the admission and management of detoxification and related things like that. But what you are trying to tell, extremely common is people, once they develop PD, they start getting suspicions about the partner, not because of anything. This is the human tendency. See, I'm not able to do or carry out some responsibilities. And in fact, unfortunately, what is happening now, the media, the fuels many of these type of things. You go to Netflix or this one, that one. In fact, every lady is having affairs, and you go to any of these soaps, you just miss one or two serial episodes. You don't know who is in love with who actually likes. So this type of confusion comes. So this is extremely common. If somebody is having ED and the whole picture looks like nothing major to be attributed, of course, the proper evaluation of ED, that means if there is anything which is contributing to it, say starting from a brief regular test, what we do, maybe starting from CBC, sugar, cholesterol, renal, liver function test, maybe in a small limited number of cases, maybe including hormones where necessary, not because of anything, but because if there is anything else, organic pathology, which can be actually responsible this thing. We have ruled out all these type of things. Of course, urologists and certain other people may do very extensive evaluation, but proper history can establish whether very often whether it is psychogenic or organic.
Yeah.
Nocturnal phenyltumescence.
We have to differentiate whether organic or psychogenic or really is a psychiatric background. Okay. So moving on to the next case, Dr. Apurva, would you like to ask this question? You are muted, Apurva.
First of all, thank you so much, sir, because you have bring out the another aspect of ED. Because everybody is like, when the person is coming with ED and just prescribe the medicines. But what you have told, that is what is the basic fundamental pathophysiology of that. And to treat that is definitely very important. Sir, thank you so much for bringing out this important point so nicely. So moving to next question, Mr. Santosh is taking a psychiatric medicine for depression, newly married, non-conjugation, brought by wife. He is always drowsy, sleepy, not getting out for any work, and definitely not interested in his new married life. So these type of questions or the type of questions are not uncommon in our practice. So sir, what you will advise in these type of patients, and what medicines you advise, what medicine should be changed, and what is the preference? Over to you, sir.
Okay. Of course, again, from psychiatric perspective, see here, there are three major aspects are there. One is actually the depression itself. The second one, the drugs which have been given. The third one, what best can be done. See, what best treatment can be chosen. So that means these are the three areas we definitely need to look into. See, when we say somebody has developed depression, see, there are depression, 13 plus categories are there in international classification related to depression. That means depression related to adjustment disorder, very simple level 2. See, what we call as the physiological, endogenous, or the primary psychiatric, major psychiatric disorder. We are all aware that depression means the three core symptoms according to ICD classification. One is actually that feeling sad. The second one, not getting pleasure out of the activities what he was doing. The third one, feeling tired. And we have other minor categories actually to explain. One of the most important thing is actually libido. See, in depression, what happens? It actually kills majority of our appetites. And one important appetite is actually the sexual appetite also. So at the basic level, one should be aware of. Second one, once we have established what type of depression this is. See, depression means whether it is, again, clinically we classify major depressive disorder, minor form of symptoms going on for a long time like dysthymic disorder, to major depressive disorder, mild, moderate, severe. That is one classification. Bipolar disorder means wherein they are depressed sometimes, but they are very highly elated, very active another time, plus quite a few other varieties. Say, coming to the drugs, what is being given. Many people have a wrong idea that psychiatric drugs are sleep producing. People invariably sleep and various things like that. Unfortunately, it is true also. What many of the drugs, many of the psychiatrists that they can produce some amount of sleep and issues. The one or two small points, because to convey the message, what is this actually antidepressant? Because we need the help of gynecologists. Because many gynecologists are a little psychiatry oriented, but quite a few people are, we don't know what it is, and all this particular way they actually neglect it off. All major antidepressant drugs, say for example, tricyclics, if you take, it acts on so many mechanisms and it can produce sexual problems on its own right. SSRIs are extremely commonly used, starting from fluoxetine, citalopram, escitalopram, sertraline, fluoxamine, and paroxetine. See, paroxetine is highly sedating. Fluoxetine is actually stimulating antidepressants. So what actually the drug which has been produced, and many of the time depressives, they don't get sleep. So doctor must have added some sedative or maybe hypnotic drug to this particular regimen. There are a few more other categories of drugs. Many of these drugs take their own time, and about 4 to 6 weeks is the minimum time that is necessary for antidepressant to act. So that is the third one. What we always suggest is, if he's an young individual, married, and likely to be concerned is sexual issues, choose an antidepressant which is actually least likely to produce problems. See, in that particular angle, say if you try to among SSRIs, fluoxetine, sertraline, escitalopram, and some of these type of drugs, they produce almost about 20 to 30% risk related to the sexual function. If you see, mirtazapam is another antidepressant, little sedating, but again 20 to 30% chances. But try to choose an antidepressant which is actually least likely to produce difficulties. One of the most recent drugs is actually vortioxetine, where sexual problems have not been reported. Vilazodone, which produces much less than even a placebo. Some of the studies what actually they have documented. TNF hydrochloride. And what we are trying to tell, if we choose those type of drugs which are actually least likely to produce problem, in fact, there is no difficulty at all. The third point, what can be done? See, if depression is very severe, within about a week or 10 days, we can make individual all right, maybe by ECT, or there are other quite a few methods of physical treatment are available. Why I am suggesting straight away ECT? Because when we are trying to look at the long-term treatment and newly married, unconsummated marriage and other sexual problems, bring him out of the depression, he will be back to normal. Even sexual functioning improves drastically with improvement in depression itself. Or try to choose an antidepressant which is least likely to produce problem. One of the classic example for very easy for gynecologists to remember is actually vortioxetine. Maybe about 5 milligrams to start, maybe about 5 to 7 days later, you make it 10 milligrams, and another 5 to 10 days later, about 20 milligrams. Very easy. Fluoxetine is a stimulant antidepressant, but not that much problematic. In fact, you try to choose fluoxetine, very easy. The linear metabolism, about 20 milligram, more than sufficient. Sertraline, about 50 to 150 to 200 milligrams, about a 20 to 30% small risk. Or tianeptine hydrochloride, which is actually very least likely to produce a problem. So try to see that with the antidepressants, he first comes out of the depression. Things may settle on its own right. If otherwise, depression is cleared, the drug you have chosen is actually the right one. The other treatments are all working all right. People suggest the antidepressant-induced sexual dysfunction can be corrected by PDE5 inhibitors and things like that. So that is another method actually one can follow. So because this particular non-consummation and newly married, these individuals need to be looked into very sensitively and handle all these things, because once a relationship is established at the end of 1 year, 2 years and all, like, the chances of breakup is very less. But in the beginning, this could be one of the extremely important and major problem, which actually leads to a lot of catastrophes related to the marriage. So attend to that particular aspect. I think I have given the wider picture of what all the things that can be done in this case.
So all those men or men who are on antidepressants, so you should make it a point to tell them also, if they are getting married, then they have to meet you and get the counseling and what drugs to be used and how to go about it. Because most of these they want to hide that they are on psychiatric treatment. So immediately after marriage, I have got quite a few patients of non-consent, all the time drowsy, not very dull, not at all interested in the girl. So she will not be knowing that he is taking some medicine also. Later she will come to know that he is taking medicine that has been hidden, not revealed at the time of marriage. It creates a very big problem, family problem between both the families, and so the whole family will come and sit in your clinic. So
Okay.
that
With a very, very right point what Dr. Padmini was making, in the sense, we always suggest if there is a problem, better to tell. See, unfortunately, what happens when you make an announcement that I'm actually having depression or other psychiatric disorder, sir, marriage won't happen and all. This is one of the other common complaints many people tell. But what I can tell at this juncture is, this can be handled very easily and properly only by a psychiatrist who is a little sensitive to how to handle this particular one. See, about 40, 50-year-old individual depression treatment is different from somebody who is getting married or recently married, or in fact, unconsummation has not happened. So remove certain drugs, add certain type of treatments, which actually can remove depression very fast. These are the few approaches one should follow.
thank you.
Very much.
Thank you so much, sir, for wonderfully explaining. And I think it's A to Z of everything about the antipsychotic patient on antipsychotic medicine. Thank you, sir. Over to you, Padmini ma'am. Yeah.
Yes. So this another case, Mamata being treated for depression. Husband is an IT professional, busy from morning till night, hardly any sexual contact. There's one of my patients, only very enterprising, very bubbly, and always in the front in during her school days and college days. And after marriage, suddenly she started becoming withdrawn and then depressed. And all the family members were wondering what has happened to her and why it is like that. So when I talked, she was already on antidepressant. When I spoke to her, she said, see, everyone thinks he's an IT professional with a fat pay packet, with a very fat pay pocket, and everyone was envying with me. So that, and you'll be so happy, and your husband is in such a highly placed position. So everyone was thinking like that. Only then I came down to know the reality. So morning till evening, he will not be having any time for me. Weekends are filled with only relatives and friends and his work, left out work, and absolutely no time for me. There is absolutely no physical contact for so many days, and hardly once in 3 or 4 months we would get to be together. And so I lost interest in everything. So people think then I have got depression. They took me to a psychiatrist and they have put me on the medicine. But the actual fact is this. So, but if even if I tell them, nobody will understand, and I cannot express this problem to anybody. That was her major problem. So, in such a condition, how do you counsel the couple? And when someone comes for depression, the other aspect of it, it is becomes very important to know what other things can be the cause for depression.
Okay. As I was that I very briefly brought in, there is something called as bipolar disorder. See, one bipolar disorder, there are multiple different ways we classify. One of the classical understanding is bipolar type 1 and type 2. Type 1, where individual is very active, mania, something you have documented, or depression, but this actually cycles alternate. But the second aspect is actually somebody who is very active, very energetic, taking up a lot of responsibilities, very bubbly. That's what actually you mentioned the terminology. There is something called as bipolar type 2. This is hypomania, wherein they are something very active, very energetic and all like that. See, however much we are active and energetic, that much higher chances of we developing depression is also there. So somebody is average, it is fine. Somebody very energetic, very active, very responsible, and a lot of things actually they do. We are also, see, for example, many of us actually we work quite a bit and we are actually made name. That means we are all in the queue for developing depression sometime or other. When we feel actually so, we have to be a little careful.
Don't create fear in us.
I am there in the queue, you are there in the queue, Apurva is there in the queue. You see, so we are all there in the queue that way. Okay, that is one aspect of it. Second one, one important aspect to handle these type of things is, nowadays this is extremely common, and in fact, this IT-BT, many doctors, many gynecologists, in fact, they are so busy that it is almost impossible to spare time, and this can lead to a lot of difficulty. That is one aspect of it. Second one, an individual is already depressed. She needs more love, more affection, and more contact. But if this is a part of depression, the depression needs to be treated adequately, properly. Otherwise, what happens, whatever amount of love and affection one may be trying to give, still it will not actually able to meet or reach her what we call comfort, because this is not something what she has invited. This is just like any other illness, that illness needs to be treated. So that is one aspect of it. Of course, we definitely do what we call as counseling. We call the partners, spend time to see that, in fact, they keep up a little bit of time together. They do a lot of activities together. These are all extremely important aspects. Sometimes there is another corollary to this. Many of the times the woman is working and she resigns and wants to take care of the house or things like that. Somebody who was very active, very energetic, and employed and what we call bubbly, suddenly do a little bit of household work and be confined to the four walls of the house, this can create a lot of problems. In fact, this is one of the extremely common problems. In fact, just about in the afternoon, 3 o'clock, one of the bank manager who resigned when the child was about 2 or 3 years old to take care of it, now she has gone into severe depression and she feels so regretful that she resigned. So this is one more other thing. Somebody who is actively engaged and all means they should actually be engaged. Of course, counseling both the partners to see that they spend time together, extremely important. And many of the times in our counseling, very small things would be triggering, and actually these things would be driving each one actually away from one another. You are not spending time with me, and she's waiting all the way, and she starts scolding when she comes back home, and lot many other such things happen. How actually to handle, how actually to get the person nearer, how actually the relationship can be built. This cannot be built on what we basically call by fighting and various things like that. In fact, how precisely this can be done. making him understand that the responsibility has to be distributed between the job and the partner. So there are multiple ways actually one has to handle this.
Thank you. Dr. Apurva, like to discuss this case?
Yes, ma'am. The next case is Mr. Naveen married to Kusuma, a case of non-conservative marriage. Husband has a low desire, taking medicine for mental retardation. When do you advise or not advise marriage for a mentally retarded person? Because it is usually not happened in our societies, because people are always hiding the fact, and they are, after that they marry, and after marriage usually they came. Sir, to what your is there any grade of the mental retardation when you are advised not to get married, or if they get married, then what the other options are available for them to counter these type of problems, sir?
Of course, both the sides of the coin we have to see, because in general, when we are talking about society, the girl is having some amount of intellectual deficit and hide it and try to arrange the marriage. The son having problems and hide some of these things, arrange the marriage. Majority of these type of things landing up with difficulty is extremely common. Now, earlier we used to use the terminology mental retardation, but now the recent classification uses the term called as intellectual deficit disorder. So this is the term. And of course, the basic parameters or the criterions are almost same. Mild, moderate, severe, and profound. And anywhere between 70 to 90, we call it as borderline, wherein he is able to do simple common things and all of that, and maybe non-intellectual talks and all he can do extremely well. And these people are plenty in the society. The scholastic backwardness to many other things what we talk about, they're all related to that area. Mild and moderate, they are educable, trainable, and they are also, in fact, they can carry out quite a few responsibilities. But the chances, sexual and other related issues are quite significant. See, less than 35, more severe and profound, no question of thinking about marriage, because these people can be trained, but educating them actually becomes quite difficult. Unfortunately, in fact, when we see the cases, he has completed SSLC or various things like that, actually they will say. During COVID-19, everybody was actually passed, even SSLC they have passed. In our schooling system, what happens is whether he does or doesn't do anything, but they are continued to be passed, and unless you spend some time to understand, you won't even know, because he has SSLC passed doesn't mean anything at all like nowadays. Or he has come up to SSLC, this is because of one important. The second one, we almost always say that these facts being hidden and then marriage, and many of the times actually they lead into quite a bit of difficulty. And even legally speaking, mental illness, or in fact mental retardation in particular, if it is documented, it was present before marriage, this can be one of the legal ground for nullification of marriage. This is there. The third one, many of the people who can manage simple things and responsibilities, there is no difficulty at all. But if there is actually something significant, this particular aspect is present, two things happen. If the partner is very well adjustable and their expectation is very low, in fact, many of these people continuing the relationship for a long time, we have actually seen. But those people who expect quite a bit, my partner should be like this, and in fact, they have certain particular ideas. These are the people actually who will end up in quite a bit of difficulty. Of course, the last point, that non-consummated marriage, what is being spoken about. See, one important point is, one is mental retardation, establishing properly the degree and extent of problem associated with it. That is one aspect of it. The other one, non-consummated for any reason, actually, among all sexual problems, handling these things are a little difficult. In fact, Dr. Padmini Prasad must be handling these cases almost day in, day out. Those who are doing well and some problem came in between, they are much, much easy to handle. See, he developed DD 1 year ago, 1 month ago, or maybe 6 months ago. It is very easy to handle. But this is an unconsummated marriage. In fact, We have come across 10 years of unconsummated marriage, 20 years of unconsummated. Maybe Dr. Padmini Prasad must have come across 30 years, all through the life, unconsummated marriage, they are going on like that. So these cases need very extensive involvement of the therapist to understand each of these problems. And many of the times, you see, for example, mental retardation issue is not there. Unconsummated marriage, I suggest them almost about 15 to 20 days of admission and the total involvement in this whole process of treatment, what we carry out. Because giving some advice and many of those type of things, what we basically generally do with other sexual problems won't work, where unconsummation is actually one of the major issues.
This is if the husband is mentally retarded and lack of knowledge or how to go about how to perform a sexual activity, it's an extremely difficult thing. But so many times I have seen wife little low IQ and somehow they manage, and I have seen loving husbands looking after them. Oh, she is little dull, but she can do the work. And family people protect them so much all the time with them. And I have seen quite a few boys who are very low IQ and mental. No, he does all the work he does. He goes to the bank. He knows how to count the money. He is a graduate and he has got, somehow there so many have got the degree, they can purchase the degrees also. So they will just to show to the girl, they say, so everything is there. And so many times the girls come and cry. I never knew anything. We are also poor. And I got 2-3 sisters to get married. And I cannot leave also and go and what to do. But somehow so many of these girls have adjusted and after the teaching and all that, some of them somehow they have managed. And the other problem is that, what about this hereditary aspect? See, for example, little low, that medium or low IQ, and how much of it is a hereditary component? How much is a child? Because that also they will ask. My husband is the dull person and doesn't have intelligence. And I am scared whether I will get a child also like that.
See, there are almost 2-3 aspects, but one can try to look into. Hats off to ladies. They are extremely adjustable, and many of the, in fact, if you take 70 to 80% of the marriages succeed not because of the men, but because of the ladies. So we men are really very well protected by the female population in Indian context, at least what one can definitely say. The second one, majority of the mental retardations, what we come across, somebody has grown up, middle-aged, or say, for example, 25, 30, 40, 50. Majority of them are related to what we call as the obstacle issues. See, I'm married to a gynecologist. I still remember quite a few of these people. See, for example, suggested cesarean section. By the time they give permission to perform cesarean, the whole lot of problems might have already happened. Baby is in distress and woman is in distress. But these people, somehow they want to see that doctors are somehow doing cesarean and a whole lot of things. Our problem is mainly looking into this mental retardation, which could have been very easily handled. And unfortunately, this is. And so much of obstacle service improvement has happened. And hats off to gynecologists again, because you have reduced a certain amount of morbidity, mortality related to this particular area. The third one, as you were telling, many of them actually, they look educated, and not because of anything, but because one thing is actually the parents, for them, the children are extremely important, and that's what actually they will tell. The second one can progress very far in education system, not because of anything, because of the flaws in the system. The third one. The fourth one, when you're trying to talk about congenital disorders, one has to just keep it in mind. See, there are some disorders where autosomal dominant, some disorders autosomal recessive, but majority of the people or any mental illness for that matter, we can talk about polygenic form of this thing. And those cases are very limited. One of the classic example we talk about is actually cerebral palsy, and these are all related to acquired in the pregnancy, at the time of delivery, or immediately after that because of one or other causes. They form the biggest chunk. If there is a family history and other related problems are there, in fact, one definitely need to look into some hereditary aspects.
Moving on, coming to it has become a very common problem. You must have come across such cases, so many cases, day in and day out. This is a porn addiction. Santosh, addicted to porn, complains of decreased libido and erectile dysfunction. Wife is quarreling with him very often. This is one scenario. And youngsters getting addicted to porn. I had one of the doctor's son only while studying there, because both husband and wife working, and then they used to leave the child at home and then go. He's very intelligent boy and very good at learning things. And one day, he was alone in the house, some of his friends came and they say, come, we'll play computer games and all that. In that, they showed some pornographic picture, blue film to him. From that time, he became so depressed, and such an intelligent boy started doing so badly in all the tests and other things. So it really caused a greatest concern to the parents, and then somehow with so much difficulty, they could get him de-addicted or come out of that problem. And today he is a very reputed person and a reputed doctor. That's a different issue. But such things can happen, and especially when the youngsters, when it comes, it can disturb so much of their activities, their academic intelligence and other things. In the husband-wife, when it comes to couple, it can again lead to so much of problems between husband and wife. So how do you go about it, and how can you cause de-addiction for such person?
I'm really happy that this particular case was brought into focus, because this has become one of the major problem in today's world. And in fact, the international classifications last 2 to 3 years, ICD-11, which is coming up to ICD, in fact, DSM-5. Now they have created a special category called as internet addiction, porn addiction, mobile addiction, because this has become more problematic. COVID and other related things actually, wherein actually people used to avoid many of these type of things, at least the adolescent group. Now this has become something extremely common, because you gave and you made them get into this. It has happened like this particular way. One aspect of it. There are other 2-3 areas we need to look into. See, the porn addiction or any addiction for the matter. In fact, these are all grouped under a special category called as behavioral addictions. Internet, mobile, porn. Many people get stuck with this, and just like any other, maybe you talk about alcohol, opium, or any other those thing, they could be as problematic, as difficult as anything else for that matter. So, handling this particular porn issue, whole range of managements would definitely need to actually plan. Coming to what actually happens with the relationship. See, when we are talk about relationship, there are 2 issues are there. The sex in the marriage or between 2 people involves a lot of effort. One is actually starting from wooing, establishing relationship and maintaining it, and performing to prove certain points actually becomes an important issue. And when we are trying to talk about performance, inverted comma, this involves a lot of effort on the part of the individual. Which are the shortcuts? See, this is one of the reasons, say, masturbation is actually extremely common among men. In fact, one of the old stories that 98% of the men masturbate, but 2% are telling lies, is actually true. Why masturbation is so common, and in fact, very commonly prevalent problem is because one person is alone and he can actually take care. Porn, when we are trying to talk about porn, see, the reality and what actually the fantasy, it actually blurs. Sex is, after all, one of the important aspects is actually it is triggered by the fantasy. And see, in fact, looking at people performing and which can trigger, and you don't have to put up any effort. So this robs the individual from putting up effort and trying to get some pleasure out of it, because this is one of the very easily available source of actually pleasure. The last point, what precisely happens is, see, this is actually true even with opium also. See, among all drugs of dependence, opium is supposed to actually create significant inhibition in performance and actually in the libido and lot many other areas, not because of anything. The pleasure what you get in the sex In fact, you are getting it much bigger way and a much easier way by using this opium. Porn addiction is almost, and one of the analogies what one can say, because this is something very easily available. So the treatment involves maybe sometimes even admission, not because of anything, but because these people have easy access and relatives and others have been not successful in this particular whole area. That means rooting up in this individual in a protected environment. This is what actually what we talk about. And these people will develop withdrawal symptoms just like anybody else. In fact, in the WhatsApp, you must have seen a particular cat making so much of fuss, and the title is, he's searching for a mobile. The same story. So one has to get him out of it, bring him into a protected environment, get him out of the withdrawal features, and the counseling and other related behavioral techniques, along with relaxation and certain other things, systematic desensitization, what we talk about. All these things may be necessary to be carried out. Now it is understood as it is as good or as bad as certain other chemical dependencies, what we used to talk about earlier, and now it is very well recognized. And maybe in the coming days, more than COVID, this may be the bigger pandemic which is going to be, we'll be facing in the years to come.
What medicines you usually give for such one?
See, for example, to control impulses. So there are a few group of medications are there. One of the easiest thing and where available documentation is actually SSRIs. See, when among SSRIs, see, there are about, to make it convenient for the gynecologist to remember, the first SSRI that was introduced was actually fluoxetine. It is a stimulant antidepressant. Not much use maybe in this, but it is immensely capable of controlling what we call impulses. The second one is sertraline. 50 to 100 or 150 to 200 milligram range, what one has to. It has some inbuilt anxiolytic property. Escitalopram, almost in the similar fashion. Paroxetine is highly sedating, but to control these type of impulses, supposed to be extremely useful. Available as 12.5 milligram, one can go up to about 40, 50 milligrams comfortably. And paroxetine is one of the drugs what actually one would be. One of the key important component in managing this type of drug or behavioral addiction is actually one has to take these individuals from the environment. That means sometimes even admission and those type of things are necessary. Along with that, one actually has to try with the medicine. But those people who are stuck, insightful and wants to come out, some of these drugs may be useful along with counseling.
So many times the wives will come and ask me, you give something that his desire can be curbed so that he will stop watching porn. They have got all sorts of unrealistic expectations.
Absolutely.
So you give me something so that I can mix with this food or the drink or anything like that I can give to him, so that he will stop watching porn. So these are all, so because sometimes they force the wife to do the whatever they see in the blue film.
That is another story.
Abuse, that turning into an abuse. So that becomes very difficult. So if they expect something looking at the blue films or the pornographic sites, and then they want their wife to do all that. So that is another type of abuse which we have seen. So,
in fact, just about, I was talking to Dr. Neena Sawant from Mumbai, and about 3 days back, we were discussing one case. In fact, this particular fellow watches porn, and one important thing is actually hitting on her buttocks. This is what actually has seen in the porn, and he is very particular about that particular behavior, which wife feels obnoxious and problematic. No, it could be very simple, this thing, but there are actually problems.
Serious turn also. Yes. Okay, thank you very much for that.
Thank you so much for giving us detail about the treatment of the porn addiction, sir. Moving to the next question. Munna is a 20-year-old, weak, depressed working, unable to sleep properly, begged me to do something. He has to masturbate 5 to 6 times in a day. He thinks he is doing a sin, but cannot sleep without masturbation. He wants to come out of this addiction. And sir, so there are two aspects of this type of question. First is the myths behind the masturbation. Because one saying is that 99% of the male are masturbate, and 1% who has not masturbate are actually telling lie. So there is a lot of myths regarding the masturbation. So I just wanted to ask you, what are the myths regarding this? And secondly, sir, how to prevent this type of cases, this type of like yeah, masturbation, excessive masturbation, which hindered the life. Over to you, sir.
See, the important point is, let me tell you about this aspect. Myself, I completed my PhD in what you call as Dhaat syndrome. I got my PhD in 2019, and this is one of the work
Yes, sir.
related to this thing. I can talk for 10 hours continuously on masturbation and issues related to it. To make it very simple, see, masturbation, as we psychiatrists or any specialist believes, absolutely normal, and this is one of the idea what we should have. The second point is, except for a particular condition called as compulsive masturbation, which could be part of certain major psychiatric disorder and all of that, one need not have to, in fact, unless you are very confident in getting this particular idea, actually can lead to quite a bit of difficulty. I still remember when I was at almost about 30 years old story, when our principal came to know that I'm going to take a class on sexual medicine to undergraduate students. He called me, Rao, what you are going to talk? I heard you are talking about sexual medicine. Yes, sir, I'm this thing. Then he told, Rao, you must talk within limits. What is that limit? Nobody knows. The same story applies to the masturbation also. So first point, as we specialists should remember, is actually whatever number, whatever he is trying to tell is absolutely understandable. One need not have to feel anything. Do within limits, try to control. Those type of words are not necessary to be told. This is the first point. The second one, see, the people believe the semen is one of the very important, extraordinary great cargo, and that should be preserved. And we have in Indian context the concept of brahmacharya, that semen should be preserved, and this is extremely important aspect. And preserving sexual energy means this particular energy can be utilized for so many other activities. And losing energy means, see, 1 drop of blood is equal to 40 drops of semen. In fact, 1 drop of semen is equal to 40 drops of blood, 500, 600 drops of blood. And I still remember 1 or 2 patients telling me it is almost equal to 1 bucket of blood. They come out with so many such ideas. And I have seen some of these books written. Maybe Ayurveda also, now the concepts have changed. Virya Nashavu, in fact, Jivana Nashant. That means what it means is in English, you lose semen means you are losing life. And many people have the idea that later they won't be able to perform. This is actually something bad. And some of the ideas what they have is actually they're not able to concentrate. In fact, eyes will sunk, hairs will grow on the palm. You will become emaciated. You lose energy and vitality. You won't be able to marry. You won't be able to produce children. Many of these type of ideas are extremely common among these individuals. Because of this, what happens? More he tries to control, more anxiety it generates. In fact, one of these old earlier Freudian concept is all the anxiety, depression, and many other disorders are related to controlling semen. And this is what precisely happens is certain physiological responses what are present, you are trying to modify it, try to control. There is no way possible at all. See, sperms, once they start growing, we are all well aware, maybe 6 days, 7 days, 8 days. That's what it is capacity. And it has to find some way out. Once the seminal vesicle is fully packed or maybe under pressure, while talking, by some simple touch or maybe coughing or straining or dreaming somewhere in the night or some other time, each of these type of things, mechanism, it comes out. Even in absence of it, it can get into urine and it will come out and all. This is all actually very well documented. So what one has to do is actually first make him well aware that this is actually not a major problem. The second one, all the myths and misconceptions related to the masturbation, semen. In addition to this, the size of the penis, this is again they are very much worried. See, more he tries to control, more flaccid it will be, and that's what actually he feels it is less. And how we comes to the size has come down. I masturbated. That's one of the reasons why it is shrinking. In fact, there is a syndrome called as Coro, wherein people believe that the penis is getting into the abdomen and various things like that. And many of these men, they go to the public urinals and all like that. The chuma don't pass urine. Who is that other fellow next side by the side? What is his size? See, by the side, the size definitely looks much better than this fellow seeing upside down. It looks small, and he will interpret in this particular fashion. So there are multiple ways he can develop many of these type of ideas. So our job is to see that, explain to them. What I do, we have some particular diagrams to how where actually it is generated, how actually it goes through, and how one of the classic example I give is, see, it is not like a coconut you are breaking and the water goes out and that is the end of the story. It is like our Shivan Samudra in Mandya, nearby that particular place. More water flows, more water comes. No, you got the point. So we have to explain to them in so many ways. And the size doesn't really matter that particular way. The second one is actually it is looking small, not because of anything, but because he's trying to control. See, the special feeding that is necessary for arousal, he's trying to block it. So these are the few of the important points. Many of these people are highly anxious, and from that particular angle, we go by some anxiolytics, some antidepressants. If he is not married and all like that, maybe adequate dose of antidepressants are that way. Some extent his anxiety is reduced, and in the meantime, we get time to explain to him all the related aspects. So these are the few approaches what we follow. Because we are gynecologists, there is one more category of problems called among females. There is what we call as psychasthenic syndrome. We have done a lot of work, and at least about 2 MD theses were related to this area, wherein loss of what we call as vaginal discharge, white discharge per vagina, and because of which I'm feeling weak, tired, and a whole lot of things actually what they complain about. This may be day in, day out issues, but this is one more area which is almost analogous to what we call Dodge syndrome in case of man.
The main problem is about this school, college going students. They come with compulsive masturbation. They cannot take up exams. They cannot concentrate, and they will look so shabby and not taking interest in everything. So that is what is the main problematic thing about this.
See, our job is to make them understand that it is not wrong. See, what actually he's telling, he has to masturbate 5 to 6 times in a day. Sometimes he might have done it. Our body's physiology doesn't allow this type of things to happen. But he interprets, he almost masturbated 5 to 6 times sometime. He will tell now that almost this is what actually the figure I'm actually masturbating. So many of the times, more he tries to control, more desire he will get, and more anxiety, more distraction, more lack of concentration, and many other such things happen. But diverting our energy to certain very constructive, say maybe the play, the reading, other activities can actually bring down a lot of such things also. There's one of the other counseling suggestions to what we actually try to do.
Thank you so much. Ma'am, over to you for the next question.
So this is Kalavati, a 39-year-old. She underwent hysterectomy 1 year back for heavy menstrual bleeding. Before surgery, she was sexually active. But now she has developed a low mood, loss of desire, and doesn't want to perform. Her husband is very angry with her. What is the cause and treatment in these situations?
In fact,
Brought in a gynec.
I'm extremely happy because this question came, and 2 important aspects I would like to discuss, because this is extremely common.
Yes.
See, normal woman's physiology, if you try to look at, primarily this is actually inhibitory type. In fact, if you take nature, whole this thing, almost always the problems are associated with the female, because anything sexual activity can create difficulty. And from that angle, arrival of oral contraception is one of the major revolutions that happened as far as the sexual science is concerned. The second one, physiologically speaking, she is almost always in inverted comma inhibitory, because There are multiple hormones. Psychologically speaking, she has not been given a free hand, and she has been almost always made to believe that it is a duty. It is a painful this thing, to many other such aspects which have been. And more than anything else, she is a woman if she is menstruating. If his uterus is removed, means that she is no more a woman. This is one of the other major idea which actually ingrained in her from the beginning. And removing the uterus means actually, it is actually taking off the womanhood. Physiologically speaking, as I was trying to talk about, relative increase in testosterone, because of which increasing libido, desire for sex, and lot many other things what actually people talk about. This happens somewhere around 40s among the women. And I have documented certain cases wherein about 20, 30 years live together. Now they are actually talking in terms of divorce and lot many other things. Two things that happen. One is actually a man develops so many other disorders, he's unable to perform. That is one aspect of it. The woman's desire increases by somewhere around 40 to 50 years. But unfortunately, many of the women who have undergone hysterectomy, this is actually the common story, because somehow I am not able to perform or participate or cooperate and various things, because it is actually the socio-cultural phenomenon rather than actually the physiological, biological phenomenon. Many women carry this particular idea. We had children, we have brought them up, they are all settled. Why actually? Because sex means it is actually procreation, and this is only the reproductive function, and this is what actually they interpret actually. Now I am totally free from menstruation and other related problems and all, like these are more than understanding in that way. This is precisely way actually. There are some people actually who have felt very active and energetic because no more menstruation and problems related, and they have become active. But majority of the women feeling bad and nervous and withdrawing from anything sexual is actually because of the socio-cultural phenomena.
Yes.
That means we definitely need to talk to them, make them understand this is actually extremely important. And of course, hysterectomy means you have a different degrees and categories actually, like say you have removed ovaries and along with that and otherwise. So those type of things. Thyroid related problems around this particular time. One of the major common problem, almost about 30 to 40% of the women having hypothyroidism and other related issues. And where necessary, the hormone replacement and all of that. So these are the few of this type of things we very strongly recommend, and we send it to gynecologist. I am lucky because I am married to a gynecologist.
Yeah.
We send them and they take care.
The main thing is that before and after surgery, there has to be a good counseling.
Absolutely.
The couple has to be counseled properly and mentally prepared for this. And eventuality, it can, for some time, it can reduce the desire. You can have low energy, but later you will pick it up. And after then they have to restart their sexual relationship and what they can expect and how they can use some, if, as you said, if the ovaries are removed, how you have to give them advice. So this counseling before and after surgery becomes extremely important in such conditions.
Thank you. Thank you so much, sir. Yeah.
Yes, Apurva.
So moving to the next question. Ankit is very talented guy. Has been in a relationship since last 6 months. Priya, his girlfriend is a bold modern girl. Once called him for a romantic date. We are tried to intimate, but Ankit was constantly avoiding penetrative sex and doesn't allow her to play with genitalia. Sir, this actually history might be indicated toward the sexual aversion disorder. So, sir, what is actually the sexual aversion disorder? What are the different types? And in this particular case and in this type of case, how you treat this?
Okay. See, I'll tell you, there was one case long back, almost about 25, 30 years ago, and Justice Saldana used to mention this case. He was one of the person who dealt one of the cases. They eloped and they went to Mangalore, and what precisely happened, this girl wanted sex, but this boy, see, we are not married yet, let us get the approval from the relatives, and then we'll actually have. Then she told, I don't want to marry you because you are not a man. and how this particular case went. There are a lot more other related dimensions are there. These are all rare. Many of the times boys misuse the whole situation, and what precisely happens to, very rarely, occasionally we come across this particular case wherein the girl is more active, but the boy would be a little different. This happens because of 2-3 reasons. So I'll tell you, one of my very distant relative got married, and issue was like this. This girl was brought up in Bangalore, and she used to go to a pub and all like with the family, and she's very comfortable about all of this type of things. This boy is from some place around Davangere and very conservative. That means we should never drink, and girls, no chance of going to pubs and drinking. See, socio-culturally speaking, a lot of such differences can come up. That is one aspect of it. Second one, when you have mentioned about sexual aversion disorder, let me be clear. This is not brought under what we call as sexual aversion disorder. Why? I'll explain to you. One is sexual aversion disorder, very rarely reported in case of males, and for all practical purposes, this is not a male disorder at all. That means this is actually knocked off. The second one, among female sexual dysfunctions, we used to talk about female desire, female arousal. And when you are trying to talk about female desire disorder, it could be hypoactive or sexual aversion like that. Now, the recent classifications, both in ICD-11 or DSM-5, this particular disorder has been knocked off. Now, this what we basically call aversion to sex is brought under, this is considered as one of this phobic type of a disorder, wherein any idea related to the sex brings about significant panic and anxiety, and because of which actually they try to avoid. So it should be treated like phobic disorder. So it has been totally removed from sexual disorders category, and it has been grouped under some other section where other psychiatric disorders are covered, say anxiety disorders around that particular area. This whole terminology, sexual aversion, has been knocked off. Coming to sexual aversion disorder, even today we come across these type of problems in women. I still remember one case. We managed this particular case for roughly around 3 to 3.5 months in the hospital half of the time, because this particular girl will not allow husband to come to the bedroom, touch in any particular fashion, and anything related to the sexual, she will create such an amount of fuss. Actually, it has to be. So the whole problem is actually the educating the individual, initially prescribing sex, that means stopping the sex. And then I still remember, practically speaking, in fact, he will sleep on his cot and she will sleep in her cot. Once they were a little comfortable and all like that, cots were moved little nearby. For some length of time, along with relaxation, she will just touch the fingers. Then she will touch both the fingers. Then she was made to touch the whole arm. And then, no, you got the point. It is a very long process and very difficult case. We have actually succeeded. Other one, sometimes another interesting case, what I can tell you is he married one cousin sister's daughter only, and 4 years, and the end of it, actually, they told, he told, I want to marry somebody else because she is not allowing me to touch her itself like that. He went next day to the house when they told, mother-in-law told him, come tomorrow afternoon, everything would be sorted out. So it was a big house, and in the center of the hall, they had put the cot. There were about 5 to 6 ladies, mother-in-law and other ladies. One person holding the arm, another person holding a limb, another person holding abdomen, another person holding head. They told him, you do it. He says he removed the pant, but he couldn't get the erection. All of them told him, you are not a man, why you are making fuss about it? I said, no, you got the point. Sometimes it is actually the girl who is having the problem, but this particular man comes back to me telling that, sir, I'm having ED, please treat me like that. No, you got the point. So history taking is extremely important, and one definitely need to look into. So sexual aversion disorder, people now believe that this is actually a psychiatric disorder, should be treated under anxiety disorder condition. All group of anxiolytics, and more particularly antidepressants which are having anxiolytic property, they are the drugs of choice. and it is easy to treat because it is now considered as one of the phobic type of disorder, and phobias, both the pharmacological and non-pharmacological treatments are available.
Thank you, sir. So thank you so much for explaining this thing. Really very good. Thank you, sir. Ma'am, over to you. Next question.
So let us move on to these topics where now it has been an inclusive society, and we have to man, woman, or transgender. We have to give importance to all of them, and it is a high time that we know about these transgenders and gender identity and all that. So that whenever now more and more gynecologists will come across such patients and their problems, and basically because it may be the woman to man, a transgender trans man, or from a man to woman, a trans woman. So we may be at some time or the other, we may come across such patients. So Ganga is a transgender. She is well educated. Now she wants to start her personal life and wants to be in a relationship, but she is scared. What are various sexual problems in transgenders? Any medicine or surgery required for smooth sexual functioning in transgenders?
Yeah. As your question itself included associated comment,
Yes.
when we use the word transgender, of course, the issue is what we are trying to refer to. In fact, that is one of the important questions. See, when we talk about LGBTQ, those who are lesbians, or those who are gay and bisexual and things like that, that's one aspect of it. There should be another terminology called as transsexual. See, for example, if you are using the word transsexual, wherein the individual feels he is trapped in a wrong body. I'm actually a woman, but I have the all male structures and which I feel uncomfortable. And a woman may feel actually, in fact, she's a man, but she's actually so transsexual man, transsexual woman, and a lot of modifications that can happen, sex change surgery and other related things. So to what level, to which category of people, what we are trying to talk to is one actually we have to establish in the beginning itself. That is one aspect of it. Second, see, for example, when we are trying to talk about transgender, those who have undergone surgery and those who have not undergone surgery, and starting from very minor procedure to sort of complicated procedures, what actually they might have gone through, there are all certain issues which are primarily. Many of the times, the prostitution and lot many other issues which are actually there, likely to be present in many of these individuals. So one definitely need to look into. So ultimately, when we are trying to talk about, there are some people who like transgenders only. Two, so the other people who are using it as a profession too, in fact, as starting a marital family life and all of that issues. So one has to spend a lot of time to establish what are the issues involved in this. Depending upon the type of problems, we definitely need to talk to. One important is actually our sensitivity to the whole issue. That transgender means it is actually something problematic. We should have to get out of it. And now the law recognizes the third gender. So it's one of the very clear cut, and they have each and every individual has the right on their own way actually to deal with their life. The second point. Third one, depending upon the type of problem. See, many of the times, say, for example, I want to start a life and I'm actually having a problem. A lot of expectation and anticipated anxiety and all might be the responsible causes. So what actually she is scared of and other related things that need to be counseled. And by chance married, each of this type of different levels, different types of problems are bound to be present that need to be attended.
But now still some of these marriages and other things is not yet accepted by law, but slowly that will come. Most of them, that's why they resort to, because they were all looking down upon and not getting educated and getting jobs. So the only thing which was left for them was begging and prostitution. So in that also they can have so many of these sexual problems, and the way they get operated, the hormones they use and the operations. it can, some of the operations, if they like any other operation, these operations also can give problem to them. It can painful, tender
But
scalp.
what is documented is actually these operations can create more problems than other common surgeries. What
They live with all those problems, and if at all they can have menstrual pain. If the, for example, if the uterus is not removed from a man to woman, so then that they can still, they can bleed and they can have some problems. And for the man to woman, and again the problem, the operations itself, that can create problem. So many of these things to be, because they also can have, like any other human being, all the problems and associated sexual problem. And most of these people, their way of sexual type of sexual activity is anal, oral. So many of these infections which can happen, and the problems with the anal sphincter and the piles and the bleeding, fissures, and also the oral infections. So all these things, they can come to any of these infections or any of these problems. So all those things have to be kept in mind when we deal with such cases. Okay, so moving on to the next. Yes, Apurva.
Vicky is now in class 11. His friends often discuss about their sexual fantasies. His best friend Ankit told that his dick is become 7 inches during erection. His another friend Rohan told him that it's more than 8 inches. Vicky is now very much tense because he thinks he has a very small size penis and he will not be able to perform. So, sir, my first question is a lot of myths about the size of the penis. So, does size really matter? And what are the different myths regarding the penile size?
Okay.
Over to you, sir.
One is, see, I used to answer one of these popular magazines, question and answers, different things. One important question repeatedly, what people used to ask was related to, see, but one of the most common thing was masturbation. The second most common thing was actually the size of the penis. And I still remember we used to write, in fact, Padmini Prasad is also very common in responding to a lot of questions and all of that. One of the most common questions from men in general is actually they are worried about the size. In fact, there's one Steckel's statement is there. Man is represented by his penis. See, depending upon the size, in fact, what type of man one can actually one can talk about it that way. So many people carry many of these type of ideas. And I shall remember one of the paper published by one Dr. Pramodu from Cochin on data related to the size of the penis, how common and what is the common size. And related things, we had one of the editorial in the Journal of Psychosexual Health. Why actually people worried about it and what actually is the issue related. In fact, this I can transfer it to you people and you can distribute it to others. It makes a very good reading. So people carry this idea that size should be this much. And if it is not of that particular size, I am actually problematic. The second one, nowadays, the porn and a lot of other things have documented very long, big, consistently erect and able to perform for a long time. I still remember when I was a young boy, one of the movies written there 5 p.m. to 5 a.m. That means progressive will perform like that. So these are all type of ideas. People get carried away that size becomes extremely important. So our job is to actually make him understand and explain that the size doesn't really matter. The vaginal sensation may be about 2.5 inches or 3 inches maximum. And anything what extra is actually bonus. Erection happens means automatically, in fact, it is the spongy tissue which can become big. Even 2 inches or 2.5 inches, 3 inches penis can become as good as maybe 6 inches, 7 inches. Many of the times, anxiety and other related things actually prevent the individual from getting adequate erection. All these type of things in very clear, simple terms, we definitely need to explain to them. Extremely common among young boys because there is nobody to tell them. And many of the times, see, there are studies related to whom these boys will talk to. One of the most common categories is actually their friends, peers. The second most common category is actually teachers. we were preparing certain NCERT related this thing, guidelines for adolescent education. When we were reviewing the data, the teachers are the second most important category of people for whom, in fact, people try to collect information. That means we need to train teachers, and maybe these boys, young boys, definitely need an idea related to what actually precisely the penis, that it is actually an extraordinary organ which can actually become big only if followed. Penis doesn't listen to. Head of the penis, in fact, there are two interesting books are there, actually, what we have read. One fellow who doesn't listen to you is actually penis. When you don't want, he is actually can get aroused. When you want it, he doesn't follow your advice or instructions. These are the two important messages, but definitely need to be conveyed. So people have a lot of such ideas and can go on narrating about the penis and size. See, many of the times these people won't come and try to tell you exactly, but it is actually the penis concerns. This particular fellow must have told a lot of people, my tentacle is not working, he will comment. Because he's a botany zoology student, he has read about hydra, sea anemone and all of that. He talks about tentacle. He talks about stick. He talks about bicycle. He talks about many other such. In fact, these are all the terminologies people use, and we definitely need to keep an idea what actually he's trying to talk about.
Your most common thing, which I remember even today, is that my little brother is not working.
Of course. My Chota beam is not working. No, beam and all UPI system. No, my beam is not working. My Chota beam is not working. No, you got the point. In fact, the number of terms actually people use maybe 100 plus related to this.
Very true, sir.
Raja is not working, so you should understand what he is expressing. Okay, thank you very much.
Thank you, sir. So moving to next question, Padmini ma'am.
So this is an important issue. Ravikant, 48 years, unfortunately, is a guy who is diagnosed with
CA lungs.
for all the treatment of chemoradiotherapy. He loved his wife very much, and he wanted to have sex life as before his cancer, after his cancer therapy. What are various sexual dysfunctions encountered after CA therapy, cancer therapy? How to treat these patients? Because they need a lot of counseling, go through a lot of emotional problems and all that had to be handled, and sometimes you may have to take psychiatrist's help also to see that they do have a normal relationship and sexual life.
Okay. Just as an introduction, about 4 years ago in Ranchi, ANSEPS, we had one whole symposium on this particular cancer and sex. That is one aspect of it. And in 2023, WPA conference on the regional congress in Malta, one of the symposium that has accepted is actually the sexuality section is actually this cancer and sex. So a lot of issues we definitely need to look into. One important thing is actually what cancer we used to talk about earlier days and what we talk about cancer nowadays. Of course, many issues are related to the cancer, where, when it was recognized, what all the treatments done, and how much recovery the individual has made. All these parameters actually determine to what extent one should be able to go. One important point is actually somebody had CA lungs and has been cured. So absolutely, I don't find there is any reason why he should not be sexually active and be participating. The important point here is actually, we are all well aware, radiotherapy, chemotherapy, and lot many other things actually interfere with many of the physiological functionings, and individual feeling weak and incapable in so many ways, and all extremely important common problems. And when we are trying to talk about sex, there are 3 different levels. One classification is actually penetrative sex. Second one is participative. The third one is actually relational we talk about. In the same fashion, there are other related terms like intimacy issues and sensuality issues, and the physical penetrative sex one may be talking about. So there are multiple levels at which, depending upon the individual's capacity, the need, one definitely look into what all the things what one can do. See, I still remember having gone to one of the functions, and it was actually related to the diabetes. One person who was chairing the session was my own classmate. He told in the beginning only, this Rao fellow is there, and he talks about sex, and you're all more than 50 plus. You don't have to worry and don't scratch your head too much. Sexual problems are not for you people. So that somebody who is chairing the session, exactly opposite what you was telling. So whether somebody is having diabetes, somebody is having hypertension, somebody is having stroke, and somebody is having CA, for all these psychosomatic disorders, the issues are very simple and clear cut. What are the best possible methods to help them overcome? And whole range of therapies, starting from being intimacy related issues to, in fact, purely physical performance, one can actually do. And when we are trying to talk about use of certain things, say something like, he's able to, the relationship is very good because partner is also very cooperative, and intimacy issues are not a major problem. Sildenafil citrate or any one of these PDE5 inhibitors can be extremely useful drugs. One can very comfortably, what one can try to use, because sildenafil citrate or PDE5 inhibitors, they act at a very local level, what we call as corpora cavernosa. Absolutely, there is no problem. Second one, try the best level possible. What it means is, if you are using sildenafil citrate, go up to 200 milligrams if there are no medical contraindications, coronary or other related things. PDE5 inhibitors, absolutely comfortable. In fact, go up to 10, 20, 40 milligrams, tadalafil if everyone is talking about. At acting central level, apomorphine, in fact, quite useful drug. One can actually combine these two things together. The third one, if there is actually some problem where nerves have been damaged, autonomic, neuropathy, and lot many other things are created because of the chemotherapy and all that, vacuum erectors. Or at the last resort, maybe the processes. So one can go up to any level depending upon what type of problem and partner issues and lot many other things. Even at an extreme form, if you are trying to look into that partner is not there, he wants to marry, what one can do. In fact, one can think in that particular line also. So all different types of therapies are available depending upon proper evaluation of him, expectation of him. One can actually plan out a range of therapies.
So at least it is cancer, lungs, he can sometimes, after some time, he may be able to perform. But if it concerns the genital organs, cancer, pelvic cancers, and so the problems will be related to that particular cancer. So depending on that, but in any cancer, it is very important to do some counseling and how to, because that is, the doctor has to talk about it. Because first thing is that they avoid talking about it. That's the main problem. But doctors should make it a point to say how to counsel them in cases of sexual functioning. We got only 2 cases. Dr. Neeraj, can we finish it up?
Yes, definitely. We will finish.
Okay. Yes, Dr. Apurva.
Yeah, ma'am. So Sanjay has had a very stressful life. Last year, he had a massive heart attack. But with God's grace, he survived and now doing well. But he's on many cardiac medicines. He feels some kind of sexual problems like ED. So, sir, how to treat these type of cases when they are on some cardiac issues, and what medicines are safe in this type of cases?
Okay, one important point. Before I get into what we basically call the drugs and related aspects and what drugs can be used, the most important point is, see, cardiac involvement or any cardiac event, many people become nervous because their sexual life has come to an end. Second, many cardiologists are not sensitive to look into this aspect, and they say you avoid, and a lot many other such very general advices are given. And I still remember one of the cardiologists telling that you can have sex with your wife, not with your girlfriend. The idea is the sex with a girlfriend would be very explosive and a big event, and with wife means it is something very simple and ordinary without much excitement. In fact, many of these type of wrong messages and all, actually many of the times we actually convey to the patients. Okay, coming to the cardiac problem. problem. See, there are a few specific contraindications have been given. Say, for example, hypertension, something like malignant, very significant, associated congestive cardiac failure, the inferior wall ischemia in particular, which can be massive and things like that. So these are the few of the things actually people have suggested one has to be a little careful. Otherwise, maybe at the end of 6 weeks or very definitively at the end of 3 months, many of these issues are not that much important. PDE5 inhibitors are considered to be one of the extremely useful drugs. And when we are trying to talk about cardiac problem, the only very specific, in some books it is written as absolute, but in some books it is written as what we call as relative contraindication. The nitrites and nitrate donors, if somebody is on, that's where actually the problem comes. There can be a very massive fall in blood pressure and the individual can land up with a difficulty. But to overcome that, what people have suggested is actually, in fact, those who go for PDE5 inhibitors of a short duration. Say, for example, skipping one dose, he gets enough time for about 7 or 8 hours, means sildenafil citrate acts for only 4 hours. Say, avanafil only for about 4 hours or maybe less than 4 hours. So, one can choose certain types of drugs in this particular fashion. The idea that he should not have sex, that is not a scientific basis at all. The second one, giving a rest for some length of time, it may be 6 weeks or maximum 3 months, what is actually advised, this thing. He should be able to get back to his usual self. Be careful about certain type of drugs what have been used. See, when we are trying to talk about antihypertensives and anti-cardiac drugs, some of them are immensely capable of producing sexual problems. See, for example, a drug like prazosin, very positive and helpful. Whereas angiotensin and something, those related group of drugs, which can actually produce inhibitory type of effect. And CD3, those with drugs which act, that means those which are inhibitors and those which are actually, in fact, can produce certain type of changes in the sense that some of these type of drugs can become more active or less active, and it can actually produce quite a bit of difficulty. So, proper history related, the type of event that has happened, associated medical and other related problems, say including diabetes and things like that. The fourth one, what are the type of drugs what he's taking concurrently, whether those type of drugs can be modified, whether some anxiolytics and other related things, whether it should be brought about, other lifestyle changes issues, say starting with maybe exercise, diet, reducing weight, and few of those other related things actually simultaneously being attended. The fourth one, the last one, the relationship issues, if they are actually there, counseling both the partners in real issues that are involved and how to go about. These are the few of the things quite useful.
Yeah, so nicely said. That's why there are also what are known as a Princeton consensus. 1, 2, 3. Now they are with the third consensus, which was there in 2010. So that any cardiac event and when they can resume sexual activity, if they are able to climb to stairs, to flights of the stairs without any breathlessness, and if they are not on nitrates, so they can resume the activity, and they can also use PDE5 inhibitors. And also that all that risk scores, they have that risk scores. So what other things they have? One thing they have to understand is penis is window to heart. Any erectile dysfunction, they should be advised to go through all the detailed cardiac investigation. Because in ED there may not be any problem with the heart, but still it can be one of the indicators of the cardiac problem, deep-seated cardiac problem or any metabolic disorder.
Now it is actually recognized that is one of the important stigmata to understand that the forthcoming or the risk of coronary artery disease in these individuals who come with.
It's very common these days to see patients. I wonder, I have got a stent in my heart, whether I can resume sexual activity. I have undergone an operation, open heart surgery 6 months back, whether I can. So this, then we have that specific question, and one should be ready to counsel them properly and give them proper advice, not a vague advice or somebody told to one of my patients, you should thank God that you are alive. Why should you worry about sex? So that was the advice given by a cardiologist to one of my patients. And because even youngsters are becoming, falling prey for this cardiac problem, myocardial infarction, heart attacks, and especially after COVID. So when the youngsters come with these problems, you should be able to give proper counseling and treatment to such cases. Thank you very much. And coming to last question of the day, Sabita is very much worried since she read an article somewhere where it was written that menopause means no sex. She is approaching 45 and doesn't want to lose her wonderful sex life. What are various sexual problems in menopause and how do you go about it, or what are the treatment?
Okay. Of course, menopause, referring to menopause in a woman itself is actually one aspect of it. There is something called as andropause, and because men actually has been separated, this is the way actually for the andropause some people write. That means men going through this particular phase in the life. See, coming to menopause, I was explaining this particular thing in relation to another case, wherein actually the woman's sexual desire increases significantly with appearance of menopause, not because of anything, but because all these inhibitory estrogen, progesterone, they are reduced and the relative increase in testosterone. So need for sex, seeking sex, enjoying sex, all of these type of things are actually inbuilt in the female sex. Menopause is not a problem at all. But unfortunately, many articles convey that message that menopause means end of the life, inverted comma, reproductive life means actually end of the feminine, in fact, feminine power or capacity, and many such things. So primarily it is a socio-cultural issue. But the other problem, what I'm very much interested to talk about in this particular point is andropause in case of men. Many women get into the difficulty not because of this thing, but because men who are quite active earlier, now they start reducing their sexual activity. They avoid, or many other such things actually happen, and which leads to a lot of difficulty. See, if you try to look at all the points for that virupas or andropause, what we talk about, there are 8 points are there, except for testosterone level, all are indicators of depression only. So keep a watch on that. Look into what all the metabolic and such other phenomena which are operating, which are age related, how intimacy and relationship issues actually can be improved. So these are all few of the things definitely one has to look into. So for the woman, we have to explain in very clear terms that actually menopause is one of the blessing in disguise, because sexually she is immensely capable of enjoying life in a much better fashion. That is one aspect of it. If there are associated problems, say diabetes, hypertension, and more than anything else, the hormonal deficiency states, thyroid, each of these type of things, one definitely has to look into and try to correct it. The last point is, if there are any problems related to the woman, now there are a few drugs are also available. Say flibanserin, brimonidine we talk about. Flibanserin act on 5-HT, that 1A, which is actually the stimulant. Of course, our experience with some of these type of things is actually limited, and what actually been even advised in the literature is also, if it is not working for around 8 weeks, there is no meaning in continuing some of these drugs. So when you are trying to talk about the female sexuality, primarily it is behavioral and other related things which actually work. Any inhibited female sexual functioning, one of the most important point is actually, in fact, training the woman in masturbation and maybe the touch and the relationship. That means the relationship building, the intimacy issues, and the sensuality issues. These are more important than actually, in fact, the man having the size of the penis bigger, this, that, and other related things. So it is a job that has to be done, and it is a worthwhile effort.
That cultural inhibition has to be removed. Menopause is the end of sex life. That's because nowadays women live 1/3 of their life post-menopause. So the quality of life is very important and the proper counseling.
More than anything, what happens actually, many women lose their husbands around this particular time. Maybe around 45, 50, 60 and all of that nowadays. Women live for much longer time. That's what actually I'm trying to mean.
They get married at that age. I've seen many people getting married for this.
So one is marriage, and even starting from use of vibrators, masturbation, each of these type of things, many people have a lot of misconceptions. You have to explain to them.
Masturbation is okay. If they do masturbation, is it a wrong thing or whatever it is? So that's so many questions you may have to face. So and it's extremely important, whatever age, right from the young age to old age. Sex has no expiry, as Dr. Jumani used to say. So that's what we can say. So it was really a wonderful session, Dr. Rao, and you gave in such an elaborate manner. You have discussed so many things about the psychiatric problems which we are not aware of. And you are talking about Freud's theories and other things. So there is an interesting story you must be knowing very well. So that he was treating one woman with, he was puzzled to treat her, and so many times repeatedly coming to him. So one of his assistants then remarked, it seems, so the treatment he wrote, prescription, penis many times. That was the prescription. Then really he said, see, when such a thing is causing so much of misery to a woman, and why this sexual medicine is not taught in any medical college. And even these things, a relationship issue, if it is causing so much of a problem, and when in his times, whatever that he told, even today it is true, still it is not yet taught in the medical colleges.
Of course, one good thing that is happening is actually now the undergraduate medical education going through a lot of changes. Now the credit point system, that way they have given enough time for psychiatry. That's one aspect of it. Second, now the students can choose some specialty areas for training. So sexual medicine is actually one of the things offered in our JSS Medical College. What we have to see is actually this particular facility available in many medical colleges, and in fact, main problem is actually many doctors, consultants, faculty, somehow they are averse to this very idea of sexual something. They try to avoid, they don't allow, and I think that particular aspect should change.
It is always clubbed with psychiatry. So not all sexual problems are psychiatric problems.
That is that. For example, ICD-11, now it has removed sexuality section from psychiatry, and it is a separate category that has been given.
Yeah,
Now,
because
the idea is all different branches have their own say in this, and this has already been separated now from psychiatry.
because
But the
usually
problem-
we talk about psychosexual, because not all things are psychosexual things. And so a perfectly normal person can have sexual problems and sexual issues. So that one has to understand that. Okay, so you explained everything in detail, and I'm sure we all had the confusion to clarity. That is
questions in chat box and all things like that. Anybody has asked some questions, means also I will be happy.
what? You see any chat box, Neeraj?
No, ma'am. There is actually, sir has elaborated everything so nicely and so detailed. I think it's really give to a clarity to everyone.
If at all, if they have one or two questions, I think we can take. If at all, if somebody has got it, or if it is time is up, we can close this also.
Yes.
Apurva, Neeraj giving vote of thanks.
Yes, sir. Sir.
Before I leave, of course, I am extremely grateful to Foxy for this wonderful opportunity to interact. 37 years I have lived with the gynecologists. I know how difficult and how easy.
How to handle them, you know very well.
Thank you, sir, for being with us. It was a really memorable and very wonderful session with you.
Thank you. Thank you.
Would like so many with more with you in future.
Yeah, definitely, sir. Sir, so should I go for vote of thanks?
Yes.
Before that,
So,
I think Madan Kadambi has fixed up along with Foxy one more program on 1st of September.
Yes.
We are talking on understanding men and women, the differences, and how this can be bridged, and how it
AMOG's program.
Sir, it's a AMOGS. Yes.
Okay.
It's a mock program.
Good.
Yes, sir. So after this really a brainstorming session, and it's really gave a lots and lots of clarity from confusion. So it's a time to say goodbye so that we can meet again and discuss the wonderful topics with some another wonderful faculty. So before that, I would like to give vote of thanks. Thanks to our Foxy President, Dr. Shanta Kumari Madam, our Secretary General, Dr. Madhuri Patel Madam, Vice President in charge, Dr. Vipin Pandit sir, and the chairperson of our own committee, the person behind all this program, our own Neeraj Jadhav sir, the chief guest for today, Dr. P.K. Shah sir, the guest of honor, Dr. Krishnendu Gupta sir, and Dr. Shrunita Tondalwalkar Madam, and the faculty for today, the wonderful, who himself is an encyclopedia, our own TSS Rao sir, for giving us the time and making this a huge success, and really it's a give a lot of clarity about this out of the box topic which we particularly chosen for today. So thank you so much, and thank you to my co-moderator, my wonderful, my senior Padmini Prasad ma'am, for wonderful co-hosting and moderating this, and to all the viewers who spared their time and make this a huge success. Thank you to
Apurva, we got one ICOG credit.
yes, sir. With that, thank you to the ICOG chairperson, Dr. Thanewala sir, and the secretary, Dr. Ashok Kumar sir, for giving us one ICOG credit point, and to our pharma partner Intars, without whom this can't be possible. Thank you so much for all the technical support, for giving us the platform. Thank you so much.
And thank you to Apurva, you also. To all the behind the curtain work.
Thank you so much. So, thank you.
Good night to you all. Thank you.
Good night.
Wonderful cases, and nice to discuss all of this. Thank you.
Thank you. Yeah, thank you, sir. Thank you, sir. We will not leave you. We will again catch you up for some another questions. Yeah, sir.
Absolutely fine. Anytime, if I know about a week earlier, more than sufficient.